Hi there, my name's Daniel Campioni-Norman and I'm an FY2 at St Heliers Hospital. Today we'll be talking about gallstone disease. This is our outline for the lecture today. By the end of the lecture, I'd like you to be able to clinically differentiate between biliary colic, gallstone pancreatitis, cholecystitis and cholangitis. I'd also like you to be aware of the different management pathways for each disease. So we're going to go over those 4 different diseases using a case-based presentation. So you've got a 37-year-old man who's come into your A&E department and you're seeing him. So he comes in and saying he's got right upper quadrant pain. He feels a little bit sick, but no other symptoms at all at the moment. So just take a minute, pause the video, and just jot down some of your differentials for right upper quadrant pain. One simple way of classifying differentials for abdominal pain is by anatomically what's in that location. So for right upper quadrant pain, we can classify it by biliary pathology, such as biliary colic, cholecystitis and cholangitis, liver pathology, such as hepatitis and liver lesions, pancreatitis, and any GI pathology as well, such as peptic ulcer disease, perforation, and obstruction. It's also important not to forget pathologies of the lung, such as a right lower lobe pneumonia, which could cause right upper quadrant pain. So far we have a 37-year-old man with right upper quadrant pain, but we don't know much else. So how can we differentiate between the different gallstone pathologies with a history and examination? So biliary colic, in the history the pain will be colicky in nature, meaning it's going to come in waves. If they've got gallstones, they may have had this pain before as well, and the pain is typically worse after eating, particularly a fatty meal. This is because this stimulates the gallbladder to contract. They may also have some nausea and vomiting. On examination, they'll have a tender right upper quadrant, but they'll be apyrexial. Moving on to cholecystitis. In this history, the pain would be more constant opposed to colicky. They may be generally unwell, and they also may have nausea and vomiting. On examination in cholecystitis, they'll also have a tender right upper quadrant, but they may also be Murphy's positive. This is when you palpate in the right upper quadrant and you ask the patient to take a deep breath in. On inspiration, the abdominal contents move downwards and the gallbladder catches against your hand and the patient will wince and may pull away. The patient will also be pyrexial. Moving on to cholangitis, again, we'll have a history of a constant pain and the patient may be systemically unwell. The patient or a partner may complain that the patient has gone a bit yellow. On examination, again, they'll have a tender right upper quadrant. You may notice that they're jaundiced and they may be pyrexial. On this slide, I just want to briefly outline the anatomy of each condition. So for biliary colic, a gallstone will exit the gallbladder and often get stuck in the cystic duct. This then causes pain when the gallbladder tries to contract against that blocked cystic duct. In cholecystitis, the stone will get stuck somewhere in the biliary tree, and this causes backlog of bile and stasis of the bile, which can lead to an infection of the gallbladder. In cholangitis, this is an ascending infection of the biliary tract, usually due to gallstones in the common bile duct, causing backlog, again of bile, and infection. Finally, you can have a gallstone pancreatitis. This is where the stone is often blocking the biliary ducts distally, which then causes a blockage of the pancreatic duct, and this then leads to a pancreatitis. So our 37-year-old man is telling us that his right upper quadrant pain is coming in waves and is worse after eating. He's not complaining he's systemically unwell, and he has right upper quadrant pain on examination, and his observations are normal, so he's apyrexial. So, given the history and the examination with this gentleman, it's likely that it's a simple biliary colic. So now we move on to investigations for our gentleman. So for investigations, you should always start off with your bedside investigations first. This includes your basic observations and an ECG. Then you'd move on to the more invasive blood tests. This would include your white cells and CRP looking for infection, amylase looking for pancreatitis, and your LFTs and bilirubin giving us a picture if there's any obstruction. Once we've done our bedside tests, we'll then move on to imaging. All patients with acute onset abdominal pain should have an erect chest x-ray looking for any air under the diaphragm indicating a perforation. For biliary pathology as well, often we want to get an ultrasound, although that's not necessary during this initial admission unless there's any adverse features. So for our gentleman, to summarise, he's a 37-year-old man with biliary colic. His bloods were all normal, including LFTs, bilirubin, amylase and inflammatory markers. His observations were normal as well, and his erect chest x-ray was normal. So just pause for a second and think, what would you do next for this patient? So for our gentleman with an uncomplicated simple biliary colic, you would just send him home. There's no need to admit him. And in this diagram here is just a quick summary of when you would need to refer to surgeons. So first you need to ask yourself, are there any adverse features? This would include signs of sepsis, if there's any derangement in his inflammatory markers or liver function tests, or if we can't control that pain. If the answer is that there's any derangement in any of these, then you need to refer to the surgical on-call team and they might do further imaging such as an ultrasound. If actually the patient's very well and we're able to control the pain in A&E, you can send them home, advise them to go on a low-fat diet, and then they may need an outpatient ultrasound and an appointment with the surgical team to discuss a future cholecystectomy. So this is a simple summary slide, just outlining the different pathologies you get and what you might see once we've done our bloods and our ultrasound. So you may just have a symptomatic gallstone disease, such as colic, but within that they may have dilated ducts on the ultrasound or deranged LFTs. The bloods may show raised inflammatory markers and the ultrasound scan may show acute cholecystitis. Below, you could also have the cholangitis picture, where they may have high temperatures and a raised bilirubin with abnormal LFTs, and again on the ultrasound they may have dilated ducts. Finally, on the right hand side, if our bloods came back and showed there was a raised amylase or lipase, we'd be thinking it's an acute pancreatitis. Now I'm just going to move on to giving you some management pathways for each condition. On this slide, we'll be talking about the management pathway for symptomatic gallstone disease. So in that top arm, this is the example of our patient in our case. So it's a gentleman with biliary colic, but he's got normal investigations. So the ultrasound does show he's got stones, but the LFTs are normal and there's no dilated ducts. This patient would be sent home on a low-fat diet and they'll have outpatient surgical follow-up with the aim of doing a lap chole at 6 weeks. In the lower part of this diagram is if we have abnormal investigations. So this could be either dilated ducts, abnormal LFTs, or both. What you do next often just depends in which centre you're working in. Guidelines advise that if we have abnormal investigations, you should do a lap chole with an on-table cholangiogram. Then, if you find CBD stones, you can do a laparoscopic bile duct exploration, or you can secure the cystic duct and then do an ERCP afterwards. They recommend this and that you don't need any preoperative imaging because actually, even if you have both dilated ducts and abnormal LFTs, the chance of preoperative imaging showing you a CBD stone is only around 30%. So it's actually more cost effective to do a lap chole with an on-table cholangiogram. However, having said that, most centres will probably do an MRCP beforehand. If they find stones on that MRCP, often they'll do a pre-op ERCP to remove the stone and then go on to do a lap chole. If there's no CBD stones, they can then just go straight onto a lap chole. This pathway talks about the management of acute cholecystitis and is thankfully a little bit simpler. So if you have ultrasound findings of acute cholecystitis, initially you want to resuscitate the patient and make sure they're hemodynamically stable. You give IV antibiotics and you give NSAIDs as well. Ideally, you want to do a hot lap chole within 72 hours. However, if the patient is particularly unwell or if they're an elderly patient who isn't fit for surgery, you can do a percutaneous cholecystostomy. This is when you do an image-guided placement of a drainage catheter into the gallbladder. In this pathway, we talk about the management of gallstone pancreatitis. So, first of all, you can grade your pancreatitis according to the Glasgow score. If it's mild, ideally we want to do a lap chole with on-table cholangiogram on the same admission. If they're not fit for surgery, we can do ERCP plus minus stenting. If, however, it's a severe pancreatitis and the patient isn't that well, we initially need to manage the organ failure of the pancreatitis, await for their recovery, and then we can do a lap chole. If, however, they're having increasing jaundice or develop cholangitis, they will need an ERCP. Following this, we again await their recovery and they'll need a lap chole. So finally, we're going to talk about the management pathway for cholangitis. Although we said that it's commonly caused by gallstones, it can be caused by malignancy such as cholangiocarcinoma. If we have any suspicion of malignancy or there's any diagnostic uncertainty, you can get a CT scan at this point. Otherwise, if we're happy as cholangitis, you would initially resuscitate and make sure they're hemodynamically unstable, and you give IV antibiotics. Then, they will need urgent biliary decompression with an ERCP. Following this, once they've improved, you'd opt for a laparoscopic cholecystectomy. So far, we've covered how you differentiate the different gallstone pathologies through history and examination. We've briefly covered investigations, and then we've whizzed through the management pathways there. At this point, it could be a good idea just to go back and look through those management pathways and just jot down some notes on them if you want, and then we can move on to these questions. So for each of these questions, I'd like you to outline how would you manage the below patients. So at this point, maybe just pause the video for a minute and I'll try and answer all these questions. So for question number 1, it was a biliary colic, but we were unable to control his pain in A&E. So as we are unable to control his pain, we need to admit the patient. Once we manage to control that pain, we can then send him home, low-fat diet, and give him an outpatient appointment with the surgeons, and on discharge to arrange a lap chole. Question number 2 says a patient with biliary colic, but the LFTs are abnormal, everything else is normal. So in our diagram for symptomatic gallstone disease, we said if there's abnormal LFTs, ideally we should admit, and you go for a lap chole with on-table cholangiogram, or, although that's the guidelines, often many centres will do MRCP, then surgery. Question 3, so we've got a patient with right upper quadrant pain, Murphy's positive, raised inflammatory markers in their pyrexial. So here we're thinking cholecystitis. So if this patient we need to admit, you'd resuscitate, give IV antibiotics, and then ideally we give a lap chole within 72 hours, but if they're unwell or not fit for surgery, we'll go for a cholecystostomy. Question number 4, so we have a patient with right upper quadrant pain and they're saying they've got the shakes. They also have a fever with raised inflammatory markers. So here we're suspecting cholangitis. So we'd admit and they need an urgent ERCP, and then once they're better, ideally a lap chole on the same admission or at a later date. Finally, question 5, we have a patient with right upper quadrant pain, normal observations, mildly raised LFTs, and then amylase of 3000. So here we're suspecting pancreatitis, so you'd admit and manage. When they're well enough, you do a lap chole on the same admission. So to summarise, hopefully by now you can clinically differentiate between the different gallstone pathologies, and you can outline the different management pathways for each of them as well. That's the end of the lecture. If you have any questions at all, please feel free to email me, and I hope you found it useful.